Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. It's always great being in India. I've been here to India for 5 times, and I get very excited every time I'm coming to India. And I would like to sincerely thank the organizing committee and Banshi, who's a good friend of mine, for inviting me. We all know quite a big deal about childhood diabetes being type 1 diabetes. We've started seeing new phases of diabetes, so we got along and learned about type 2 diabetes. But what we have been also learning is a third phase of diabetes in children, which is neither type 1 nor type 2. And that's what I'd like to discuss with you in the next 15 minutes. So I'll just give you an example of the types of diabetes I'd like to share with you. This is a 5-year-old boy that have been referred to our clinic because his diabetes was not really well controlled. So he presented with signs and symptoms of diabetes at 6 weeks of age when he presented with diabetes ketoacidosis, and I have never seen a HbA1c of 18%, which he had at that time. Of relevance, he was born small for gestational age, and his parents were first cousins. Investigations done for that child, or even prior to the investigation, if you look at the family tree, you see multiple children within the family affected with early onset diabetes. HbA1c is very high, but this boy has negative autoantibodies, a feature that we are used to see positively in type 1 diabetes. He has no C-peptide indicating severe insulin deficiency. He had anemia, neutropenia, and at that time, he had a slightly elevated ALT. We suspect monogenic diabetes, and his whole exome showed a mutation in EIFAK3, which is a transcription factor known to be important in beta cell transcription and secretion of insulin. So this is a syndrome called Walcott-Rallison syndrome. Many colleagues in India have presented such a syndrome in multiple conferences, including ours, the Arab Society conferences. So I'm sure this is nothing new for you. So if you talk about monogenic diabetes and highlighting the genotype of that big umbrella of disease of monogenic diabetes, it can be easily divided when we talk genetics into those with beta cell function or dysfunction, insulin receptor defects, or monogenic autoimmunity. The last one is really fascinating, and I hope time will allow me to give you an example of that. And if we transform that genotype in a phenotype, we will be seeing all those spectrum of diseases under the beta cell dysfunction of MODY and others, insulin receptor defect, as well as the monogenic autoimmunity that we have heard about. Now, type 1 is important, type 2 is important, but monogenic diabetes is equally important. We need to know about it and we need to diagnose it correctly so that we can select the best clinical management for it. We need to know about it because it comes as a consortium or an umbrella of other systemic diseases. We can predict the course if we know the diagnosis. We are enabled to do the genetic counseling if we manage to diagnose it, as well as we can diagnose this disease correctly in other family members. We have been getting so advanced in molecular genetics, and monogenic diabetes is critically important. Genetic testing is important for us to employ and understand further the targeted therapy, precision medicine, personalized therapy. There's a lot of great examples about pharmacogenomics and pharmacogenetics when we talk about monogenic diabetes, and I hope time will allow me to show you a very good example of how monogenic diabetes diagnosis can apply for precision medicine as well as the pharmacogenetics. We need all to remember that type 1 diabetes is unlikely if there were no islet antibodies and if the stimulated C-peptide is still there many years after diagnosis. And type 2 is unlikely if there's no marked obesity and no features of insulin resistance. These are the basics that we need always to remember. Do, ladies and gentlemen, revise the clinical guidelines of ISPAD about monogenic diabetes, because that's very important. And for us clinicians, we need to think about it if diabetes presents in the neonatal period between the birth and 6 months, but also we need to consider it if diabetes presents between 6 and 12 months if there were no autoantibodies. You might say, okay, why should we bother? It's not a common disease, and you might be right, because it's not a common disease in Europe or America. However, in our region, it is relatively common. When we looked at our statistics, in a place like Saudi Arabia, for example, it's 5 times more common than that in Europe. And similarly, in our region, when we looked at Abu Dhabi, United Arab Emirates data, we found that it is quite high in comparison to Europe and the United States. And we have really interesting, fascinating spectrum of monogenic diabetes that we have published over the years. When we wanted to compare the underlying genetics of monogenic diabetes, specifically neonatal diabetes, between us, Arabs, in the Middle East region, and our colleagues, British cohort, we found that there is a very different etiology for neonatal diabetes in Caucasian compared to us in the Middle East. So this is data that we put together for 88 Arabs compared to 77 British. And it's very interesting because what we found is in our region, Walker-Trallison syndrome is the most common cause for neonatal diabetes, while in Europe, specifically the UK, they have KATP channel mutation as the most common cause of neonatal diabetes. This is a picture of a boy with Walker-Trallison syndrome where you see that there are multiple systemic involvements, skeletal issues, bone marrow issues, etc. And there has been multiple cohort on this disease described from our region. So my cohort at the middle of UAE has only 25 patients. However, more recently, my colleague Samar Hassan from Sudan has reported 63 patients. So it's not an uncommon disease. And the gene I described is a gene that is expressed in multiple organs, so bone marrow. So these children will have pancytopenia. It's in the kidneys, so they have kidney cysts. It is, of course, in the liver. Liver is the most important organ in terms of mortality because these children do not die of diabetes, but they die of liver failure. This family, for example, that I have highlighted, 6 children affected. All these 6 children have unfortunately passed away with liver failure from the disease. We have then collaborated with colleagues from Exeter and put together this paper, which highlights that Walker-Trallison syndrome is actually the most common cause of neonatal diabetes in consanguineous family. It's not KATP channel mutation, which is a known cause in Europe and outside. Liver, do remember, ladies and gentlemen, when you diagnose a child with neonatal diabetes, specifically Walker-Trallison syndrome, to monitor the liver function, because that's what kills these children. There are few children who had elective and emergency liver transplant that are in the literature, and it does help to keep those people or children alive. This is a paper that we have reported in a family where Wolff-Raynaud syndrome was quite common and parents were quite young. So we managed to help them with pre-implantation genetic diagnosis, which they have received in London, and they managed to get a healthy baby done. So this is very important, genetic counseling, because it can give hope to these families who were unable to have healthy children. A similar scenario in another child who also presented early undetectable C-peptide, very similar story and a positive family history. So this is another cause of neonatal diabetes, that is insulin gene mutation. Very similar presentation, but a completely different reason. Some in vitro functional studies show that the gene expression is very low, as well as production of insulin. KATP channel mutation is a very interesting disease, and it's actually good news to have the child diagnosed with KATP channel mutation amongst neonatal diabetes causes, because this disease can be treated by sulfonylurea. I'm sure you are all aware of this being a hot topic in the early 2000s when this article appeared in New England Journal showing the effect of sulfonylurea on the mutant KATP channel. So these children can be switched from insulin to sulfonylurea, similar to this child I'm showing a picture of, who was referred to us with a severe DKA. We got few children with KATP channel mutation, and I would like to highlight here the ability of you and I converting these children to sulfonylurea. And if you don't have the experience like I didn't have, there are protocols on how to convert from insulin to sulfonylurea. And I'd like to highlight here something completely different, which is the importance of use of technology in treating neonatal diabetes. So this is a little girl whom we diagnosed a few months ago with neonatal diabetes, and she was beautifully managed with patch pump. The last example on monogenic diabetes, the neonatal one, is TRMA, which is thiamine responsive megaloblastic anemia, autosomal recessive disease. It's not only that the anemia gets improved by giving thiamine, but also diabetes control is improved. As you can see here in this article, where the HbA1c goes down, not with consolidating insulin treatment, but also with provision of thiamine. This is the last case I would like to discuss with you in my last 2 minutes of the talk. So this is a 9-year-old child who had eczema, recurrent infections, dysgammaglobulinemia, autoimmune anemia, autoimmune thyroid disease, growth hormone deficiency, juvenile rheumatoid arthritis, and enteropathies. At the age of 7, she landed down in my clinic because she developed type 1 diabetes. These are her parameters, but importantly, ladies and gentlemen, her antibodies were all negative. We started her on insulin treatment, and I just would like to pay your attention to remember all these forms of autoimmune diseases that can trigger monogenicity. So we all know about the FOXP3, but IL-2 receptor, RA, interleukin, we've learned about these interleukins during COVID, but this middle one in particularly is important in triggering monogenic diabetes. This poor girl, she also presented with hyperpigmentation. She failed her synapsin test, and she was diagnosed also with Addison disease. She had mutation in IL-2 receptor antibody. This is one form of interleukin which caused her to have this dysregulated autoimmunity that was triggered by the underlying monogenicity of this. In my last 30 seconds, I would like to conclude, ladies and gentlemen, by saying that neonatal diabetes is an important cause of monogenic diabetes. It's not uncommon in our region, and I assume in India it would be the same. We need to raise suspicion and awareness. It's a very good example of precision medicine. So we give thiamine to improve anemia and diabetes. Think about using of technology in these youngsters, and think also about autoimmunity can be triggered by monogenicity as an important cause of diabetes with multiple system involvements. 5 seconds is given back to you, and thank you very much indeed.